There is a presumption that you have the following. You are proficient in ICD-10-CM specific guidelines and the general CPT guidelines and HCPCS Level 2 guidelines. If you're an MCDC student, you should be in Part 3 of the MCDC course. If you're an a la carte student, you should have already completed Parts 1 and 2, and you should be in Part 3. YouTube students, you should have completed the first 12 weeks of the YouTube course. And if you haven't, it is okay. Before I get going, I have to read the copyright. CPT is copyright of 2025 AMA. AMCI trademarks are Keyword Concept, FTR, Chun, AMCI Fab 7, AMCI ICD-10-CM Flip Tap, and MCG. These are all registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. CCA, CCS, CCS-P, RHIA, and RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. All right, so the goals of the presentation. We're going to continue practicing coding ED facility charts, right? And in that vein, we're going to review the 2 ED records that we assigned as homework. We are going to, yes, make the distinction or hopefully emphasize that coding for ED is coding for the facility, right? Yeah, the facility, not the professional. You're going to learn more about how to assign emergency department acuity points. We're going to do E&M quick reviews. So this is going to be helpful for you if you want to kind of really solidify your understanding of evaluation and management. Now, that's on the professional side. And of course, this whole thing, we are going to do practical applications. All right. So, last week we learned about the East D facility coding those reports. We learned about acuity point system. We did a quick E&M review and we assigned the homework. And really quickly, I'm not going to be long. For those of you that are new, let me get rid of this button here. Yeah, we're going to get rid of that button. And if you haven't, please remember to like this lecture, especially if you like it, right? Okay. So, when you're coding for the ED facility, you are coding for that emergency department. And this is quick, okay? You're not coding for the provider, the people. That's what the CPCs and the CCS-Ps do. You are coding for this facility and use of that emergency department resources, right? And they assign the same codes as you would for the professional. They assign their codes look just like E&M codes, so people really get confused. Yes, a level 1 ED facility is 99281. A level 2 is 99282. And yes, it is called straightforward. Oh, let's go back. Can I go back? Yeah, a 99238, it is a level 3, and that is a low level. 99284 facility is a level 4 facility, and that's moderate. And you also have a 99285 level 5 or high facility. Yeah, it does look like E&M. And that's why some people get confused when you're coding it, including me, right? I have to keep telling myself, you are coding for this facility. Stay focused, Mrs. J. Now, this is how we assign the facility code. We use this ED acuity chart. This chart was created by AMCI. However, CMS provides the instructions. And also, AHIMA has a chart that's very similar. And we've kind of created this chart in accordance and modeled it after the AHIMA chart, but we used the current guidelines. All right. So essentially, when you, and just take a look at the chart, you just, follow the events on the left and then you assign the points. And at the bottom, you determine the level of the service, the level of the ED, emergency department service. Essentially, it's got point values, then your corresponding codes are here. But most important, you're going to have to answer the following questions. What are the number of medicines given during that encounter? Not the ones prescribed, but given during that encounter. What is the degree of the medical decision making? Yes, the E&M medical decision making. So yeah, you got to know how to code for that provider. Even though we're not coding for the provider, we need to know what the provider's level of decision making was. You also have to document the number of tests ordered. And if you've got panels, do not split those panels. Code one panel as one test and the number of supplies. Now, let's get into our homework. And before we do that, I just want to show you something. This form is called a UBO form, a UBO4 form. This is how facilities bill. This form is back in the old days. The facilities used to actually use this form. Now we use, computers and software, but the software is built into the system, but it's set up the same exact way. And the thing that I really want you to pay attention to is this first column. In this first column, you have, let's go back. You've got revenue codes. These revenue codes are specific to the service that was rendered in the outpatient hospital. So we see this 0300. This tells me that this is a general lab. A general lab was carried out. In fact, if you punch in this code 36415, you might not know what it is, but it's venipuncture. I used to work in insurance, so I kind of know some codes on site, right? So this is a venipuncture. It's a standard lab, and this is the HCPCS level 1 code or the CPT code. It's right here. And essentially, that is what we're doing when we are abstracting the documentation. We are abstracting the CPT codes and ICD-10-CM codes if they're applicable, right? But the ICD-10-CM codes go down here. They go down in this section. See? And this is not even a ICD-10 code. This is an ICD-9 code. That's like, I think, no, it's not abdominal pain. I can't remember. Maybe it's chest pain or something like that. But essentially, this is what we're doing. We're going to put our CPT codes here. We're going to assign a revenue code, and we're going to put our ICD-10 codes down here. All right. So I just thought I would tell you, I'd give you some context. Now we are going to go to Jasmine and we're going to code out her chart. But remember, we have to do the following. We got to determine the first listed diagnosis, any secondary or additional diagnoses. We're going to have to determine that procedure, determine the E&M medical decision making, and then finally we're going to finish it off by using the ED facility chart to determine the level of service. And that's it. Okay, that's it. It's a lot. I know. All right, so here is our scenario. I'm going to read the scenario, and if you've done the homework, feel free to put your answers in the chat. All right. Patient, Jasmine Carter, date of admission 4/1, date of discharge 4/1. History. The history is problem-focused history. History of present illness. This is a 16-year-old African-American female with pierced ears who, while removing her sweater, got it caught on her earring, accidentally pulling the earring out and lacerating her left earlobe. past medical history. The patient has a history of childhood asthma that has not occurred for several years. Allergies. She's allergic to penicillin. She has no chronic medications. The review of systems, that means they reviewed her body systems. It says the patient has been well. Her physical examination was problem focused. And the MDM, well, the MDM is low. General appearance, this is a well nourished 16-year-old Black female in no apparent distress. The HEENT, head, eyes, ears, nose, throat, normal except for 2 lacerations of the left earlobe. Her neck veins are flat at 40-degree angle. No nodes felt in the neck, carotids, or groin. Carotid pulsations are normal. No brutes heard in the neck. Chest was clear on percussion and auscultation. Heart is not enlarged. No thrills or murmurs. Rhythm is regular. BP is 130/80. Liver and spleen are not palpable. No masses felt in the abdomen. No ascites or ascites noted. No edema of the extremities. Pulses in the feet are good. Impression. Laceration of left earlobe. The plan is to suture the left earlobe. The treatment. Following infiltration of the areas with xylocaine, the laceration was a single layer closed with 2 Vicryl. 2 suture kits were used. Initial doses of Biaxin and Demerol were provided in the ED. Discharge diagnosis, earlobe laceration of the left ear, instruction on discharge, Demerol by mouth, 50 milligrams, every 6 hours is needed for pain, Biaxin, 500 milligrams, by mouth, POs by mouth, BID is 2 times a day for 10 days. Follow up in the surgical clinic in 7 days. And this was authenticated by Dr. Angela Thompson, MD. Okay, coders, is the authentication appropriate? That's my first question for you. Type your answer in the chat. I'll give you a moment. I know when you might be like a couple of seconds. Okay. Okie doke. Well, I would like this doctor to have dated it, right? Make sure that date is there. If it's not dated, it's not authenticated. Okay, I'm not doing that on purpose. I'm not trying to rhyme. All right, so our first task is this. We need to determine the first listed code. We have the following: A, H92.02. You know what? You can put your answers in the chat if you already have an answer. Go ahead and put it in the chat. But otalgia, left ear. B, S01.312A, laceration without foreign body of left ear lobe, initial encounter. C, S01.311A, laceration without foreign body of right earlobe, initial encounter. D, S01.112A, laceration without foreign body of right eyelid and periocular area, initial encounter. Or E, H93.292, other abnormal auditory perceptions, left ear. Outstanding. 100% everyone said that it is B. However, I did do an inventory because, we got to code those secondaries too. So I went through the documentation, and this patient has a laceration of left ear. You always grab that final diagnosis from the final diagnostic statement or the final impression or the discharge summary. That's really good to do, because if the doctor says it in the final diagnostic statement, you know what? It's true. It's true. Now, if he says it in the present, history, if it's said in the history of present illness, this is the patient talking, right? So this is not necessarily true. Even though you can code here, you have to prove it throughout, by reading the body of the documentation to just make sure that it's accurate. Now, I also document it after removing the sweater because there could be an external causes code, right? And also, this patient has a personal history of asthma. It's not current. She had it as a child and she had it for it hasn't occurred for several years. And she also had an allergy to penicillin. Coders, do you see anything that I may have missed? Could I have missed anything? And trust me, that is possible. You should see this team. My team and I, we go through these scenarios over and over, and each time often we see something that we may have missed. We're not generating these scenarios. AI is generating the scenarios for today. And when they do it, they could miss some stuff, right? And we could too. So if you don't see anything else in my inventory, I want to go on. And I'm going to say what you said, that the laceration of the left ear will be my first listed code, and you find that at B. And if you said that, outstanding, outstanding. Now, we have to go ahead and determine the secondary or the additional diagnoses. So we've got A, J45.909. If you think that should be coded, put it in the chat. Say J45.909. And that's unspecified asthma, uncomplicated. B, Z91.010. This is allergy to peanuts. C, T36.0X5A, adverse effect of penicillin's initial encounter. D, Z79.899. This is other long-term current drug therapy. E, Z87.09, personal history of other diseases of the respiratory system. F, Z88.0, allergy status to penicillin. Or G, none. Encoders. If you select none, that means that you cannot select. There are no appropriate codes on this list, right? Okay. So I see a lot of people saying unspecified asthma. Well, the patient has a history of asthma, and she hasn't had asthma for several years. And she's 16, several? Okay, so we have to deduce, because of this language, that this patient no longer has asthma. It's childhood asthma. So she has a personal history of asthma. Now, coders, when we're coding these personal history codes, you don't code, you only code things that are pertinent to your encounter, right? So somebody might say, well, personal history of asthma is not pertinent. Personal history of asthma will always be pertinent. Think about this. Anything that deals with your respiratory system, that your lungs are, they're vital. They're a vital part of you. Anything that deals with your heart, your lungs, those need to be specified. Okay? Any allergies should be specified. So that brings me to F, allergy status to penicillin. Indeed, you will need to code them. But other than that, this patient no longer has asthma. She has a childhood history and hasn't had it for a while, but it is substantiated that she does have a history. We can code it. It's pertinent because it is vital to her survival. You all are rocking in the chat. I see those light bulbs going out. So yeah, we're going to code both E and F. And hopefully, I hope that's an aha moment for you. Now we're moving on to the procedures, right? So what took place? Well, I'm going to inventory. From this documentation, down in the plan and the treatment, I was able to see that this patient had a single layer closure of the earlobe, right? I kind of got a little ahead of myself. Let me take that off. A single layer closure of the earlobe. There's no doubt about it. But I also see that this patient had some medications. Remember, we're coding for the facility. And remember that UB04 form that we completed? Indeed, we're going to have to put each of those medications on that UB04 form. And so therefore, we need to code it. So down in this section, I think my thing is off. Let's go back. I'm going to just point to it. So she was treated with Biaxin and Demerol in the ED. And we're going to have to code for the Demerol and the Biaxin. And if you look at our procedures, we don't have a, well, we don't know if this F and G are the procedure, right? We don't know. What is this? Is this Demerol and Biaxin? Are these the generic terms? We don't know. So, okay, coders, you're going to watch me go down, not a rabbit hole, but you're going to watch me dig through my books to kind of deduce what should and should not be coded. All right, so we need to code for Demerol, right? So I'm going to my HCPCS Level 2 manual. And if you're taking the CCS, you can't even go in your HCPCS Level 2 manual. You can't, right? But I got something else for you. So we have our HCPCS Level 2 manual now, so I'm looking up Demerol. Demerol, it gives me the code J2175. Okay, well, neither of these are J2175, and they're not coding for Demerol. So we know that. And I'm just going to put that there. The next thing is this Biaxin. I looked up, or I tried to look up Biaxin in the HCPCS Level 2 manual, and it wasn't there. But what I do have is my ICD-10-CM Appendix B. I have the Optum ICD-10-CM Appendix B, and it's pharmacology. Okay, coders, if you have your ICD-10-CM in your possession and you have the Optum, go ahead and turn to Appendix B. If you have a different one, I want you to locate your pharmacology section in your ICD-10-CM manual. So I'm going to give you a minute to look for it. And type in the chat. Let me know if you have used or not have used your Appendix B pharmacology section. And I know it helps you with coding, your ICD-10-CM, but in this case, we need to know what the heck is Biaxin, right? What is Biaxin? It's not in the HCPCS Level 2. So I went to my ICD-10-CM manual and I looked up Biaxin. It is in alphabetical order, and it's also clarithromycin. That's the generic term. It's an antibiotic, right? And it also gives you more information about it. So essentially, it tells you what people use this for. And, it's a lot, but mainly It's an antibiotic. So now I'm just going to put here next to Biaxin that this is an antibiotic. And how I need to know if J1170 hydromorphone is an antibiotic or if J0585, this injection of onabotulinum toxin A, is that an antibiotic? In fact, I know what this is because I see my bow and I see the tox. I know what this is. So I'm going to go back to the HCPCS level 2. Tell me, what is this onabotulinum toxin A? What is it? Well, it doesn't say what it is, but it tells me the code J0585, which is here. And also, when I look up Botox, J0585. So I know J0585 is Botox. So this is the name, and the point that I want to make is that drugs fall into classifications, right? Yeah, so they fall in these specific classifications, and the classifications are going to help me determine if Biaxin is in the same classification as this Botox, and if Biaxin is in the same classification as this hydromorphone. But I already know that Botox and Biaxin are not the same. I just do, right? And so I'm going to reference this drug class chart. Now, all drugs pretty much fall into one classification. There are about 50 of them, and they fall into one. So I'm just going to kind of scan my charts and just observe. You have your you have your analgesics. This is for pain. Excuse me. Yeah, it's pain. You have your anesthetics too. That's for pain as well. You have your antibiotics, and they, break them out. You have your anticoagulants, and they pretty much prevent blood clots. You have your convulsants, they prevent seizures. Your antidepressants, right? We know what those do. You have your antiemetics, and that prevents nausea and vomiting. You have your antihistamines, right? So those are for allergies. And also, they use antihistamines for GERD and ulcers. Who knew? You have your antihypertensives, right? You have your ACE inhibitors, your ARBs, your beta blockers, your calcium channel blockers. You have your antipsychotics, your antivirals, your corticosteroids, your diabetes medications, your diuretics. You have your lipid lowering agents, that's for cholesterol. You have your neuromuscular blocking agents, you have your sedatives or hypnotics, and you have your thyroid medications. So most drugs fall in one of these classifications. So I'm just going to look at these classifications, and I'm going to figure out if the drugs on my list or of the same classifications as the two drugs in the list or the options, because that'll help me determine whether or not I should be coding it. Well, the first box, we have analgesics and anesthetics, right? And right in here, you see your hydromorphone, its own, that suffix. That suffix tells you that this is an analgesic, specifically an opioid. And if you don't know that, many of us know oxycodone, right? We know that. So this is used for severe pain. And let's use our common sense. Would a doctor typically administer a severe pain drug for an ear laceration? I don't know. Usually they administer that for severe pain when you have surgeries, um, you know, pain. You know what I mean? So I'm going to say maybe not. But we already have our pain code, our Demerol. Demerol is pain, and it does fall in this section too. All right. Also, this antibiotic section. This penicillin. Well, we know that this doctor didn't give this patient penicillin because she's allergic, but it's in here. That medication, we've already determined that Biaxin is it falls under antibiotics. It is an antibiotic and it should be here. But it is that Botox, right? Botox is a neurotoxin agent, nerve blocking, right? Or muscle blocking. That's why people inject Botox in their skin to prevent or to limit or to block wrinkles in the forehead or anywhere on the face or anywhere. So Botox, although it is used for cosmetic purposes, it's also used for a lot of nervous system related illnesses, right? Nerves, neuro. So again, Botox is from the neuromuscular blocking class, and Biaxin is pain. It's in this section. Excuse me, it's not pain. Excuse me. It is antibiotic, and it's found in this section. All right. So if we go and we look up our hydromorphone in HCPCS level 2, it is sitting there, and the code is J1171. So if you looked it up, you would know that the code is wrong on our sheet, right? So we can get rid of F because it's coding it incorrectly. And also, we can surely get rid of this Botox because that is a drug for treating the neuromuscular system, and this patient had an ear laceration, a skin condition. So I am deducing that Demerol is not on our list. Biaxin, the antibiotic, is not on our list. So we will not be coding them. And the only procedure that we have left to code is the single layer closure of the earlobe. Okay, coders, of the following: A, 12011, simple repair of superficial wounds of the face, ear, eyelids, nose, lips, 2.5 centimeters or less. B, 12001, simple repair of the scalp, 2 centimeters or less. C, 12051, intermediate repair of the face or ears, 2.5 centimeters or less. Or D, 12052, intermediate repair of the face or ears, 2.6 to 5.0 centimeters. And E, 9928325, modifier, emergency department visit, expanded problem focused. Well, I'm not going to deal with the emergency department because that is visit, because that is next. We specifically request that information on number 4. So the only thing that we have is a single layer closure of the earlobe. Okay, coders, which one do you want? A, B, C, or D? Type your answers in the chat. And no, you do not, if you're not taking the CCS, you do not need this book. If you're not taking it, keep your books, keep your cost low. If you are taking the CCS, then I highly recommend it. If you are not, and you already have your books, let's keep our costs low. All right, coders. Overwhelming. You all overwhelmingly said A, and that is correct. It's a simple repair of superficial wounds of the face and ears. We cannot code this as an intermediate repair because there is no mention that this is intermediate, right? There's no mention that this is a layered closure. There's no mention. We cannot code something that's not there. So if it's not intermediate, if it's not stated as intermediate, if it's not stated, then it will be simple. Indeed. All right. So I think this is a blunder. I think that the documentation should. Oh, no, excuse me. It says single layer. I apologize. I was about to get on chat about that. It's a single layer. Single layer is simple repair. You all. That's right, Miss Haley. They're on fire. Fire, fire, fire. Okay, coders, are you with me? Everybody with me? Because now we're going to move on to 4, and this is where we'll need to determine the evaluation and management medical decision making. Okay, Britters, she says she's ready. Let's go. All right. So we know that this is low MDM. It says it in the documentation. So we don't have to do anything. We just have to assign the code for low MDM, right? So we have, oh, let's go back. So the MDM is low. And yes, we are going to assign a 25 modifier to it. Why? Because she had a procedure, a significant and separate procedure. But coders, I would not be teaching if I didn't go ahead and demonstrate using the PDR chart. But before I go ahead and do that, I want to prove that this is low MDM, right? This is our opportunity to do it. Now, before I go and do that, does anybody have any question or they doubt that that 25 modifier should be on that E&M code? Anybody need to know why? I know I just said, it's significant and separate E&M service. It is. So you can put that 25 modifier most often when the patient is having surgery or surgical procedure in the ED. All right, so here's my PDR chart. And essentially, I'm just going to tell you that I think that this is a low, acute, uncomplicated injury. One acute, uncomplicated injury. Does anybody see anything else on this list? Does anybody think that I may need to consider something else? Could this be moderate? Type in the chat. I don't see anything. There is one acute illness with systemic symptoms. There's no mention of any systemic problems like fever, right? Yeah, so I like it. I think it's low. Now we have to move on to the data. This is where we're going to see what data the physician used to determine their diagnosis. And I've said that this is minimal data. There's no data in this documentation. Okay, coders, if you can't see my screen, you can go ahead and click on that broken square at the bottom. Click on that broken square and enlarge your screen. Does anybody think that there's some data that I may have missed? Are there any tests, or did the doctor review anything, order anything? Type in the chat. Let me know. I could have missed it. All right. So I'm saying no. No data. Next, we have to figure out the risk. What is the risk? Well, coders know this off bat. Anytime a physician prescribes medication, the risk is moderate, right? It's a moderate risk. The doctor prescribed Demerol by mouth and by Axon to be taken twice a day, 10 days. So the risk is moderate. Now, coders, we have a situation. We have a low problem, a minimal data, and we have a moderate risk. So when you have three different levels of PDR, so they're not all on the same level, they're all different. When it's different like that, you're going to have to level. You got to use the leveling technique. Okay, coders, if you can level this, go ahead and level. Type your answers in the chat. I'm going to take a break and let you do that. What is the answer? Somebody said they want a copy of this chart. This chart is in your MCG manual. If you don't have an MCG manual, you can use the chart in your CPT. In the E&M section, in the green pages, you see a chart similar to this. Not this chart, but it's similar. Okay? All right, so type your answers in the chat. And I appreciate all effort. I do. Okay. So, since everyone's not answering, it's okay. You level by throwing out the lowest. And the lowest is this minimal or straightforward. I should have said minimal, straightforward, excuse me. I'm throwing out the minimal or straightforward. And then you code the next level, and that is low. So the MDM is low, just like the doctor said. The MDM is low. All right, coders, how do you feel? Doing good? Type in the chat. I need to know. I don't like to keep going, and I know time is limited, but I don't want to leave you. All right, so now the next task is we have to determine the E&M MDM. We do, right? And we said that it was low. And we said that we would use 99283 25 modifier because the patient had a single layered closure, right? So 99283 is the answer. Now, we have to determine the ED facility level of service. Okay, let's go back. I don't want to go too fast. So is it level 1, 2, 3, 4, or 5? And the way we're going to do it, we're going to use that acuity chart, right? Yes. And we're going to answer these 4 questions, right? And the first question is, what are the number of meds given? And if you look at your documentation down in the treatment, 2 medications were given. Biaxin and Demerol were provided in the ED. Xylocaine is not, it could be a medicine, right? It could be. So if you want to go ahead and say xylocaine, to me, it is it could be. It could. I can't even deny it, right? But I'm thinking of it as in anesthetic, but work with me. All right, so I'm going to say 2. Also, what is the degree of the MDM? The MDM is low. What are the number of tests? 0. No tests were administered. And finally, what are the number of supplies used? Well, it says that the patient they used 2 suture kits on this patient, so it's 2. So I'm going to go ahead and I'm going to use my acuity points chart. The number of meds given, I said 2. If you want to say 3, go for it. Go for it. I think we're going to end up the same place. All right, the degree of the MDM is low. The number of tests ordered were 0, right? And this is 0 to 1, so we can give it a chip. And finally, the number of supplies is 2. And let's add it up. If we add up this column, that's 10. 10 plus this column is 10. And if you didn't see, this is 2 units of 5. 2 times 5 is 10. And this third column is 15. Your final, oh, my adding looks crazy, is 35. There you go. It's correct. So 35, we have to go and look, where is 35 on this chart? And 35 on this chart is level 2. And coders, if you gave it another point for that extra medication, that's not, I'm still sticking with this. I'm sticking with this. This is not a level 5 for me. I mean, this is not a level 3 for me. This is a level 2. And the number of meds. I'm thinking administered, okay? I'm going to do my research, but let's keep it there. This is the anesthesia. All right, so 35 gives you a level 2. This is a level 2 encounter. So if we put it all together, B, your first listed code is B, S01.312A. Your additional diagnoses are Z87.09, Z88.0, and at 3, they want to know what is your procedure. We only have one procedure meeting the requirement 12011. The MDM is 99283.25 modifier, and I'm giving it a 2, level 2 for my ED facility. So coders, when you did your homework, were these your answers? Or maybe not. Maybe you had an aha moment. But nonetheless, the moral of the story is that your ED level and your MDM, they're not always the same. So don't think you should make them the same. Okay? Now, I want to just remind you that we will be needing to complete this form, and we will put our revenue codes here and our description and our CPT codes here next time, right? But I want to get to Mr. Holloway. And I know that we're going to run over, as I always do, but if you can stay, please do. Our patient is James Holloway, medical record number 963-25874, date of service 8/31/2025. Attending provider is Dr. Sarah Patel, MD. Chief complaint, ankle pain. Mr. Holloway, history of present illness is Mr. Holloway is a 19-year-old male presenting with right ankle pain after twisting it while playing basketball earlier today. He reports swelling and difficulty bearing weight, but denies numbness, tingling, or prior ankle injuries. Past medical history? None. Medications? None. Allergies? No known allergies. Review of systems. Positive for ankle pain, swelling, decreased mobility, Negative for fever, chest pain, shortness of breath, physical examination. Vital signs, BP 118/74, heart rate 84, the RR is 16, temp 89.4 degrees Fahrenheit, SpO2, pulse ox 100% general, well-being, no acute distress. Right ankle swelling over lateral malleus, tenderness to palpation, decreased range of motion, intact distal pulses, no deformity. Diagnostics ordered, X-ray of right ankle, ED course in medical decision making. X-ray showed no acute fracture consistent with lateral ankle sprain. ACE wrap applied, crutches provided, RICE instructions given. RICE is the acronym for rest, ice, compression, and elevation. Patient was counseled on return precautions. And the final impression, this is the final diagnostic statement. Acute right ankle sprain, disposition. Patient discharged home with crutches, advised outpatient follow-up in 1 week, and this was authenticated by S. Patel, MD, 8/31/25. All right, coders! Is this authenticated properly? Type your answers in the chat. Come on. You know what? Maybe we're a little slow. I'm slow. I'm delayed in seeing your answers, but I know you're saying yes, yes, yes. I see it. That's right. Karina, Evan, Karen, Chetna. It is properly authenticated. Now, oh no, what happened? It's okay. All right, so the answer is B. And the reason this is answer B is because this patient has a sprain of other ligament of right ankle initial encounter. If you think that we need to, say A, put it in the chat. And I'm going to tell you why it is B. A is the code for sprain of unspecified ligament of right ankle initial encounter. Coders, the doctor specified the ligament as lateral, so it's not unspecified. And also, I'm going to eliminate right ankle pain because right ankle pain is integral to the right ankle sprain. And also, I'm going to document that this patient has a twisted ankle playing basketball in the event when we grab our secondary diagnoses that we have, we have it here. Now I'm going to move on to the secondary diagnoses, and the right ankle sprain is our answer. That's our first listed code. All right, so that leaves us with the twisted playing basketball. And now I'm going to read my answers. All right. So A, M25.571, this is pain in right ankle. Not going to code it because it's integral. R26.2, difficulty walking, we're not going to code it. R22.41, this is localized swelling of the right lower limb. R252 is pain, unspecified. Z72.3, lack of physical exercise, they're making it up. Z13.6, encounter for screening for cardiovascular disorders, or G, none. Coders. There's nothing here. So if there's nothing there, then you need to select none. Yeah, let's get rid of it. None. Some of you are saying C, but isn't localized swelling integral to the ankle sprain? Yeah, a lot of these are just integral, so we are not going to code them. So the answer is G, none. Now let's move on to 3. What is 3. Oh, and also I have a little note to remind you. When you select none, you may not select any other code on your list. Whenever you're doing a multiple select exam, CCS people, CCS-P people, multiple select, you may only select none when that is the only option on the list. Now it's time to talk about these procedures. Here is my inventory, and I got my information from this section down in the ED course in medical decision making. They did an ACE wrap, they gave him crutches, and they took an x-ray. And I'm still saying none. Do you know why it's none? Because on this list, because the first code is an x-ray of the ankle. It's a complete one with a minimum of 3 views. There's no mention of the number of views in the documentation. So the answer is not on the list. Letter B, 29515, application of short leg splint. They did not give this patient a splint. They just wrapped his ankle. C, 29540, this is strapping of the ankle and or foot. There is no mention of any strapping. D, 97760, orthotic management training, initial encounter. Now that's going overboard. They did not do anything, provide him with any type of orthotic. If they did, they didn't document it. And finally, E is incorrect because this is an x-ray of the ankle, 2 views. We don't know how many views this was. This could have been just some quick x-ray inside. I don't know what it was, but this is not on our list. So coders, if it's not there, it is none. Now we have to figure out the E&M, the professional code, so that we can figure out the facility, right? So let's go ahead and determine what the problem is. He's got a sprained ankle. This is a low acute, uncomplicated illness to me. Sorry, this is off. I tried to fix it, but I may have fixed the interns, but it is in the low range. It is 1 down. Anybody disagree? I think this is very similar to the previous encounter. It's low acute, uncomplicated. Now the data, what did we do? Well, the doctor read, did he read it? It's not called read. He reviewed. First of all, he ordered the x-ray, right? Ordered the x-ray. Then he reviewed it and he saw that there was no fracture. He didn't read it. You know who read it? The radiologist read it. And the doctor, more than likely, just reviewed it. Now, if the doctor read it, then we would be down here somewhere. Or he might be able to charge for it separately. All right, now let's go to risk. You know what I noticed? They didn't give this man any pain medicine, right? No, they didn't. And this is wrong. He wasn't given any pain. See, my little checks are off. He's minimal. He's straightforward. They really didn't give him any pain medicine because he wasn't in any kind of distress. And they just told him to rest, put some ice on it, put a compression on it, and elevate that ankle. This is minimal. So we've got a low problem, a low data, a low risk or minimal or straightforward risk. So anybody want to level this and tell me what the answer is? Go ahead, type your answers in the chat. Yes, you're on fire. You are on fire. That's right. Britters, Yvonne, Vina D, Ya, Haya. I think I'm saying it. I hope I'm saying it right. Karen, Chetna. Okay, you are right. We're going to level it. We're going to throw out the lowest, which is your straightforward or minimal, and we're going to code the next one low. It is a low MDM. And if you think about it, it really is low. They took an x-ray, told them to rice, right? So there was no kind of surgery. So 99283 is a low medical decision making. Now it's time for us to figure out what the facility is. What is this level? Remember, we have a low MDM, and we're going to use the acuity points. Yeah, those answers are flying. So we got to answer, what are the number of medications given? I said no. No medicines, 0. What is the degree of the MDM? Well, we know that's low. What are the number of tests that were administered? 1 test. They had an x-ray. It's different than that data, right? But 1 test. And the number of supplies used? I have 2, ACE wrap and crutches. So I'm going to go ahead and I'm going to use my acuity point chart to score it. Number of meds given is 0. There's no option for 0, so we're not going to score it. The degree of the MDM is low. The number of tests ordered, 1. 1 x-ray ordered. The number of supplies used, 2. So let's go ahead and add it up. This column, the total is 5. This 10-point column, the total is 10. This 15-point column, 15, and the answer is 30. So if we go and we search where 30 falls, it falls right here. And this is a level 2 E&M facility. And the moral of the story, the E&M level is not the same as the ED facility. And these are the answers. Okay, coders, how do you feel? There's your answer key. I don't know about this procedure. I'm getting rid of that. No chat. You know, when you see these green boxes, you know chat gives that to you. So I'm going to say I disagree respectfully with your procedure because it was not specified. All right, coders. So we have some homework. This will be your homework. Give me a moment. I need to grab your link. I started to grab it and I kind of forgot to place it where I need to. So give me a moment. I'm going to put it in the chat. And if you have questions, coders, please type them in the chat. And we only have one chart because this chart for next week, this chart is a little more complex And I just don't want to overwhelm you. I really need your attention on this. Um, Let me make sure. Yeah, this is it. Okay, I need your attention on this chart, right? And this chart is going to um, kind of feed us into the next subject, right? And next week, we're going to demonstrate a facility UB04. So not only are we going to code this chart, we are going to code this chart and we are going to put it on the UB04. And then we're going to have another conversation on ambulatory payment classifications. Someone wants to do PCS. You want to go live for PCS? Okay, AMCI instructors, you've heard it. You heard it here. They want live PCS, but this section is all about charts. And we're going to ultimately move into inpatient coding.